Gastrooesophageal reflux. Disease in infants. Key points. Gastroesophageal reflux. Disease. GORD, should be differentiated from physiological gastroesophageal reflux, which is common in healthy, thriving babies and does not require specific investigations or management. GORD is not a common cause of unexplained crying, irritability or distressed behavior in otherwise healthy infants. Empiric use of acid suppression for unsettled infants is not effective and may cause harm. The natural history of GORD is of resolution with time. Any therapy commenced should be reviewed regularly. Background. Gastroesophageal reflux, GOR, is the passage of gastric contents into the esophagus, often with effortless vomiting, or posits. It is a physiological process that occurs several times a day in healthy infants. Gastroesophageal reflux is common, affecting at least 40% of infants. Usually begins before 8 weeks of age, peaks at 4 months and resolves by 1 year of age in majority of cases. Does not cause crying and irritability in healthy infants. Infant crying peaks at 6 to 8 weeks, and hence some babies with simple GOR may also be unsettled. Rarely require investigations. Can usually be managed with parental education, support, and anticipatory guidance. There is insufficient evidence to support the diagnosis or management of silent reflux. Gastroesophageal reflux disease is when GOR causes vomiting with refusal to feed, pronounced irritability with feeding, aspiration, chronic cough, wheeze, blank, hematmesis, cow milk protein allergy, CMPA, can present with similar symptoms to GORD. Blood and/or mucus in stool, chronic diarrhea, or atopic risk factors make this diagnosis more likely. See flowchart below. Assessment. Both GOR and GORD can be diagnosed on detailed history and examination. Direct observation of a feed by an experienced clinician can be particularly useful to identify exacerbating factors. Reconsider diagnosis if any of the following red flag features are present. Symptoms. Vomiting that is bilious, has onset and GT 6 months of age, or is consistent and forceful. Significant diarrhea or constipation. Fever or lethargy. Signs. Abdominal rigidity. Hepatosplenomegaly. Bulging fontanelle and/or increasing head circumference. Management. Investigations. Investigations for GORD, such as barium contrast radiography, pH probe, endoscopy, are rarely necessary, and are not diagnostic. Investigations should only be considered on an individual basis after the patient has been assessed by a pediatrician. Treatment. Simple GOR can cause considerable parental distress, and requires reassurance, support, and anticipatory guidance. General measures. May minimize symptoms. General measures. Positioning. Holding the infant in a head-elevated position for 20-30 minutes after feeding may reduce GOR. Prone sleeping or inclining the sleep surface is not recommended in infants due to the risk of SIDS. Thickened feeds. In bottle-fed babies, thickened feeds may reduce frequency of vomiting. Anti-reflux formulas are pre-thickened, or alternatively a thickening agent can be added to a standard formula or expressed. Breast milk. Thickened feeds can contribute to constipation. Ensure the infant is not being given sodium alginate, Gaviscon infant registered, as co-administration increases risk of bowel obstruction. Optimize feeds. Observation and assessment of feeds by an experienced lactation consultant or maternal child health nurse, MCHN, can be helpful. Assess feed volumes in formula-fed infants to identify overfeeding. Reducing feed volumes can reduce regurgitation but should only be considered if excessive for infants' weight. Consider a trial of smaller, more frequent feeds in these infants if practical. GOR alone is not an indication to change formula or stop breastfeeding. One particular brand of standard cow milk formula does not confer benefit over another, nor do they vary in their content of dairy. Specific measures for GORD. Consider cow milk protein exclusion. Up to 40% of infants presenting with symptoms of GORD will have non-IgE-mediated cow milk protein allergy, CMPA. Symptoms usually occur within a few weeks of exposure to cow milk protein. There are no specific distinguishing features that can predict response to dietary modification, nor are any investigations helpful in CMPA. Where CMPA is suspected, the infant should have a 2-week trial of strict cow milk protein elimination from their diet and referral to a pediatrician arranged. Blank. Formula-fed infants require extensively hydrolysed formula, obtained via prescription from a pediatrician. Over-the-counter formula options include Novolac Allergy Registered or Aptamil Allerpro Registered. Consider acid suppressant therapy. Acid suppressant therapy may be indicated in specific patients with GORD, see flow chart. When commenced, it should be instituted as a 4-week trial. Omeprazole, a proton pump inhibitor, PPI, is the recommended agent. Omeprazole, and LT 10 kg, 5 mg once daily. Omeprazole takes 4 days to reach maximum effect. Studies have indicated that PPI therapy may lead to an increased risk of community-acquired pneumonia, increased risk of gastroenteritis, increased future fracture risk, micronutrient deficiencies. There is no evidence to support empiric use of acid suppressant therapy as a diagnostic trial for irritable infants. It is important to review ongoing therapy and cease at 4 weeks if no benefit. Surface agents. Surface agents such as sodium alginate, Gaviscon infant registered, increases viscosity of gastric contents and can reduce episodes of visible regurgitation. There is little information available on efficacy and long-term use in infants. Is not recommended. Management flow chart. Surgical treatment. Surgical approaches, e.g. fundoplication, are reserved for children who have intractable GORD symptoms unresponsive to medical therapy, or with significant complications. Consider consultation with local pediatric team when red flag features present. Infant clinically unwell. GORD not responding to initial management, or commenced on acid suppressant therapy. Consider transfer when child requiring care beyond the comfort level of the hospital. Blank. Parent information.